But again, it's also a review of my practice. I mean, it's not just lung cytology that I'll be talking about, but everyday issues, scenarios that come into play in obtaining a good samples in lung cytology over here. That would be the focus. And with that, I think it basically is time to start. So rapid on-site evaluation comes to mind. The first thing when you talk about lung cytology in my practice, it is a collaborative exercise. Basically, that's what we do in our practice. Pretty much every single sample that comes to us, we provide rapid on-site evaluation. And again, it's a collaborative exercise between either the pulmonologist who's doing the EBIS procedure or the interventional radiologist who might be performing these procedures via CT guidance, or even the surgeon. In our practice, even the cardiothoracic surgeons do EBIS procedures in the OR at crack of dawn usually, for some reason when they are trying to operate on patient and they want to stage it before proceeding forward. So again, this is basically a review of how the practice works. The pulmonologist basically preps the patient up for an EBIS procedure, and then we are physically there with our microscope and looking at the sample itself. So again, being physically present is really important in getting a good sample upfront. So in our practice, we have about 11 locations that we have to take care of in different parts of the hospital system. Some are within the same building, some are across the street. So again, because of this, we have staffing for it. Our cytotechnologists are physically present at each and every procedure to obtain the material from the pulmonologist or the radiologist or even the surgeon, if the case may be. So I can't physically go to all these procedures as an MD who's participating in the process. So that's why we have implemented telepathology, and what it entails is this cart. There are 11 carts for 11 locations. These are physically stationed there. Each of these carts has a microscope and of course all the material that you need for completing the procedure. And then basically great communication is needed. So this is right outside my office. This is as an example. I'm just showing you that our cytotechs are physically there. This is the structure. The microscope is there, but along with that, this image is basically projected onto the screen right next to it. This is for the benefit of the practitioner who's doing the procedure. If it's a pulmonologist, they want to know, what are you seeing? Because I can't have the cytotech move away from it to have everybody coming to the scope. So as they are driving, whoever is doing the procedure can take a break and come and take a look at it. It's usually the surgeons, they are really interested in kind of looking at what is being obtained. So for their benefit, we have this screen available right next to it. But how do I get involved in it? There is an individual mobile phone that the cytotechnologist has with them, and they can call me, and then I can be physically present on my scope and look at these cases away from the site. So again, there might be 3 procedures going on, but through the web-based system that we have, that same image can be downloaded to my desktop, and I can give a adequacy assessment in real time for that procedure. So that has been the standard of care going on now for at least 8 to 10 years in our practice. So this has really been quite successful in implementing and getting a good sample up front. So our participation has increased several folds, and these are billing codes we use for pathologist participation. As you can see, initially, because only one pathologist available for the procedure adequacy assessment, we were not able to go to quite a few of them, and that had its own effects downstream. So again, our participation has increased, and we have been able to see several fold increase in pathologist participation. So this is an example. I mean, the needle has been placed. This is a CT guided procedure. As you can see, large speculated mass, operator experience equals successful outcome. That is the key over here. I mean, if we are physically there, we can actually see what's going on, where the needle is placed, what the radiologic presentation of the tumor or the lesion in question is like. So again, integrated participation in the procedure is very important in obtaining a good sample. So biopsy specimens in lung cancer, of course, a tissue biopsy can be obtained at the same time, but we are there mainly for FNA procedures. And if an exfoliated sample is obtained, such as a bronchial brushing or a bronchial wash or a lavage, that can also be taken care of at the same time and collected by the cytotechnologists before they head back to the laboratory. But FNA is the main goal there, because that can be read and interpreted in real time. And again, with pathologist assistance. So it just doesn't entail looking at a lung lesion, but again, sampling of lymph nodes in an EBIS procedure is now the norm. Sometimes it's the only procedure that is performed that the lymph node itself is sampled, because it has a large tumor focus, and that gets sampled and collected and interpreted as such. So these are the samples, and again, the images show you what they can all look like in appearance once the specimen is processed. The diff quick, the pap stain smear, and then the cell block, and then exfoliative samples, and then the biopsy samples. In our institution, since it's subspecialized, the cytology samples come to the cytopathology section. The tissue biopsy gets separated and it goes to the subspecialist thoracic pathologist who signs them out. So that's the key over here. You have to also communicate with the thoracic pathologist if that is part of your practice, that the specimens are separated. It should not be done in isolation. If I have a sample, FNA sample, which is certainly showing malignancy, and I can certainly render it, but it's always good practice to pick up the phone and check what the status of the biopsy is. Sometimes it may delay your case because those cases come out a day later. But again, communication is what my message is to you. Key factors for adequate specimen handling. Smearing is very important in real time. Learn how to make a good smear. Try to, if this is the upper part of the smear, I mean, just put 2 or 3 drops here, let a second slide lie flat on it, and then smear it evenly. These smears should be well collected. For diff quick or air dried samples, completely air dry it and then look at the specimen. For specimens that need to be stained with papiniculae staining, those should certainly be placed immediately in alcohol. So that's basically what you do. Whatever is left in the needle hub should be collected for a cell block and processed and looked at in greater detail for confirmation of what you thought on your smears in real time. So ROSE has its benefits. You can confirm, or you can also confirm there's no tumor present. It's a non-neoplastic process. And then in those cases, if microbiology is needed, you can send the sample off for microbiology. Or if you are suspecting a lymphoma, you can collect for flow cytometry, and a portion of the specimen is submitted in RPMI to hematopathology for further analysis. So just some other samples, how they are collected. This is basically giving you an overview of smear, a clot for cell block, and then this is RPMI for flow if needed. And then these are some of the smears, both diff quick and a well-preserved smear of papiniculae staining showing some tumor cells. So this is the bronchoscopy without ROSE. That can also be done if you are not physically present. Then certainly what you can advocate is you can ask the pulmonologist to do multiple passes, and then you can either have somebody make smears if even that is not possible, then it can be collected in liquid-based cytology specimens, or just directly put in formalin, 10% buffered formalin, and basically processed as a cell block. I would not advocate it because, again, it detracts from the final outcome because communication is missing here. And I basically have set up a service where rapid on-site evaluation is the norm. The only outlier situation is late nights. If for some reason no staff is available, then we can't provide it. Or the weekends, generally we try to be available for that. We have a call schedule, and that can be certainly taken care of that way. So FNA, this I've already described. What you do is you make 2 smears for each pass that is given to you. 1 smear is air dried with DiffQuick on site. This is the one that is evaluated for adequacy. Now remember, the word adequacy does not mean a diagnosis. Adequacy means it's a good sample of whatever the final diagnosis would be. It's essentially a prelim impression of what the lesion is. The final diagnosis is yet to come later on after the pap stained smear has been looked at. It may take a while. Also, if you have a cell block, that has to be reviewed, and all 3 components of the FNA specimen have to be put together for a final diagnosis. So calling something adequate on site has its repercussions, certainly, but what you are doing is you are indicating to the pulmonologist or the radiologist that they've given you a decent sample which would yield a diagnosis. Factors influencing diagnostic yield. Certainly, there are certainly factors that can impact the collection. Number of aspirates performed. Ordinarily, we do not advocate more than 5 needle episodes. Pass 1, pass 2, pass 5. You can get 5 passes for these maximum, because after that the yield tends to become lower and lower because of bleeding mainly. So try to get the best outcomes out of your first 3 passes if that is possible. And then obviously the nature of the lesion itself, the size, the location, that will also impact the final outcome. Specimen handling, obtain adequate material, apply optimal techniques. These are again to be looked at. Make proper smears. The air dried smear should be completely air dried. Again, that I cannot really focus enough on, especially in my practice for my trainees, that it's important to air dry it, because if you start staining wet dried material in DiffQuick, everything looks malignant. So that's not to be done. And then of course collection is important, because cell blocks, as I will come up later on in my talk a little bit more about it, have really come into play regarding their utility in lung pathology. And then rapid on-site evaluation again should be implemented if at all possible and your system allows it. Collection and handling of thoracic biopsies and cytology specimens, these have been certainly advocated for by numerous societies. It's now an interdisciplinary representation in various platforms that is focused on optimization and collection of these specimen types. These are really small samples. These are valuable samples, and of course should be adequately processed, and they should be standardized. So again, that's the goal regarding the specimen collection issues that can come into play. What are the modalities that are used? Majority of these cases are collected with EBUS, which is basically done by a pulmonologist for the most part. And again, central based lesions, these are very helpful for proximally or centrally based lung lesions to be aspirated, and even lymph nodes can be sampled. Navigation bronchoscopy, again, it's a combination where EBUS as well as a CT scan is applied simultaneously, and this can be useful for peripheral and small lesions quite optimally, and is a little bit time consuming, but again with practice our pulmonology group has really become quite good at it, and we have been getting good samples with navigation bronchoscopy. Other rarer modalities are robotic assisted bronchoscopy. I don't have much experience in this, but again, this is also being used in some of the centers in the United States now. But by and large, it's the EBIS specimens that we would be looking at, and that would really be the focus of this talk. So essentially, immediate assessment is what we do, and we really need to be good at it because there are several issues: adequacy of the specimens, collection for a good cell block, not just for confirming your diagnosis, but also for ancillary testing that would be required of you. So this would be what a smear would look like on a diff-quick stain. This is a well-prepared smear, completely air-dried, background has quite a bit of blood, and then, overall, what this is indicating to you that this is only blood. But again, it's really showing you what a nicely stained diff-quick smear should look like. This is a little bit more optimized here, diff-quick staining, a nice, well-preserved lymphocytes. There's no air-drying artifact here. You can really see that it's somewhat of a monotonous population, and basically this, in case that a suspicion of a lymphoma is considered, then you can collect for flow additionally. These are basically H&E sections of a cell block representing a lymph node. Similarly, representing a nice robust sample here. And then this is a smear of a well-collected diff-quick smear representing an adenocarcinoma with the necrosis in the background. I'm showing these basically to show you what diff-quick staining, air drying, and optimal staining should look like as basically a representation of your sample. And this would be what a smear with Papanicolaou staining should look like: well-preserved cells. Again, no air drying artifact here, like no one has left these lying on the table before putting it in alcohol in real time. So again, if a cytotechnologist has collected it, will be well collected, and no artifacts would be encountered. FNA specimen processing. So again, depending on your practice, I advocate for 2 slides to be prepared: one diff-quick, one pap stained slide for each pass that you are given, and the rest collected for a cell block. Cell block methods, these are really important, and I don't know which ones are being used commonly here locally, but there's a long list here. You can make a selection and optimize that process. It's basically up to your lab director as to which modality they want to use: plasma thrombin, histogel, colloidal Bragg, or clot method. So let me briefly kind of give you an overview. This is basically the plasma thrombin method. Basically, it really emulsifies the cells and agglutinates them, and again, it requires a little bit of expertise. I have not really used this in my practice, but certainly you can use this modality. The other one is a more automated process. This is from Hologic. It's the Salient method. Again, not much needs to be done by the laboratory processor. Again, you place it in the machine and out comes a pellet, but there are some issues with this process. It's basically exposure to alcohol. So that's basically what can impact your cell block later on for both in IHC as well as molecular testing. So I would not advocate for this processing method. This is something I have used and can use again in the future. This is the colloidal Bragg method. Is anyone familiar with this? Okay, so basically this is a flammable liquid material. It should be performed under a hood. Take a test tube, place colloidin, it's a liquid. You basically place it inside the test tube and it will emulsify. And what it does is it creates a bag. So what you do with your FNA sample or a cytologic sample is you spin it down and put the pellet inside this bag, and then just take the bag out like so, and then that is wrapped up over here and placed in for basically routine H&E processing. So again, it's a very simple, clean-cut process. You essentially obtain almost all the cells that you obtained for further evaluation. But this is, I think, the most preferred way and most clean way. And these slides, I've really been fortunate to get from Peter Ely at Hopkins. And what we do over here, even in our practice, is we collect each pass, the residue, as a clot. So pass 1, 2, and 3 collected on this filter paper here, it tends to clot, and you let this kind of stay in this position. And as the passes are given to you, you basically use 2 or 3 drops from each of those passes, and the rest of them are placed on the paper, and then you let it sort of air dry, and it basically forms a coin-like appearance over here. It really air dries, and then when you place this for H&E processing, this is what you're going to get out of it. So again, simple process. Basically, it is being prepared for optimal diagnosis as well as for molecular testing. So it has really been very useful for us. That's what we use, and it is advantageous. No special equipment is required. It does not interfere with rapid on-site evaluation, and definitely has superior tissue volume with great tissue preservation that can be noted in these samples. So again, this is what I would advocate for, especially for lung cytology samples when you prepare a cell block. So rapid on-site evaluation terminology for reporting respiratory cytology. This is what I will be focusing on today. Basically, it's a 6-tiered system ranging from inadequate to malignant, just like other systems. This was presented to us by the PAP Society in 2015 and then published in 2016. And this is what we have used in our practice for the past couple of years. This is what I have experience on. However, just a disclosure here, recently the WHO has come out with a new standardized reporting system. But since I have not used it, I cannot really advocate for it at this time. But looking at it, more or less, it recaps what the PAP Society has initially laid out for categorization purposes. So that was my disclosure there. Category 1, basically we are talking about non-diagnostic specimens. What are non-diagnostic? Basically, they are not providing you with any useful information regarding the clinical lesion that has been aspirated, whether it's really blood that you are encountering, or you are encountering air drying artifact, or you are just not able to basically make a diagnosis. So over here, what are these? Certainly these can be tumor cells. This may happen in the month of July. We have some new people on staff. So again, this is an example where, wet fixed material was placed for staining, and you can really not decipher what these cells look like. So this is basically what would represent non-diagnostic. Similarly over here, a blood clot, on a smear. What do you do with this? Easy enough, non-diagnostic. Similarly, if there is crush artifact, this may have embedded tumor cells if that was what was sampled, but I or anyone else cannot certainly make a call based on this in real time. So these would be some examples of this categorization. Also remember, with EBUS and sometimes even with CT guided procedures, bronchial epithelial cells can be a problem or a challenge, but look for the cilia that may come with these cells, and that basically indicates benignity, and in a way that is contamination, where these cells are picked up along with the needle tract that the lesion is being used for sampling. So again, this would still be categorized as a non-diagnostic sample and not representative of a tumor such as that you see over here. Category 2 is a negative for malignancy categorization. Again, negative indicates basically a non-malignant, non-neoplastic lesion. It can certainly indicate infections, inflammatory conditions, granulomatous inflammation, infarction. and the list can go on. So again, these are bronchial cells. Now in this context, it may be a little different, because if the clinical impression is that this is being done for a benign lesion that they want to sample based on the clinical information, this would not be called as non-diagnostic, but may represent lesional tissue. Similarly, macrophages, when noted, can certainly be in the context of pneumonia, be considered as an adequate sample and still be called negative. So this is something that needs to be considered based on the clinical information that you have. This is an interesting smear based on the fact that this was something that ended up being taken out. So anyways, so basically what you see over here are a lot of blood vessels here, but these are all macrophages over here. A lot of vessels, and this is a prime example where the experience of the pathologist comes into play. So clearly almost looks like granulation tissue. This is the pap stained smear, a lot of vessels, quite a few macrophages, a few pneumocytes also admixed, but overall indicative of a benign process. This presented as a large lesion. It came to the consensus conference. I honed in on the fact that please consider this as a negative call, and basically recommend this to be followed up as a medical process and call it, representing resolving pneumonia. So this was actually called out as atypical because for some reason that individual wanted to not miss out on a cancer. And obviously I can't really fault anyone, because if there is an adjacent area which looks angulated and speculated, could this be the periphery of that lesion? So again, in this case, follow-up showed basically resolving pneumonia and no cancer was detected. But be careful when you have something which looks like granulation tissue. It could just represent basically benignity and basically resolving pneumonia. Non-necrotizing granulomas, again, this is obviously an easy call. If there is a concern for tuberculosis on necrotizing granulomas, further workup can be done, but categorization is negative. I mean, these are just considerations for discussion. Here, atypical category, just like urines, I'm not really in favor of utilizing this category. It is still embedded in the classification system, so use it judiciously and use it for cases where your concern is for malignancy rather than as a benign process, such as over here. I don't know what this sheet represents. There is some size variation of nuclei, but certainly it does not look like an outright call for malignancy. So again, have a high threshold for making this call in your samples. If you're providing rapid on-site evaluation, then this should not really be happening very frequently, because you would have, by your mere presence, be able to obtain a good sample and be able to characterize your specimens adequately. So category 4, based on the PAP Society reporting system, is the benign neoplastic category. And again, all these unusual tumors which you see, ranging from SFTs to sclerosing pneumocytoma, pecomas, meningiomas, myoepithelial neoplasm, they have been found in the lung as a primary lesion. And basically, if we are not aware of them, then we may miss out on them. So some examples of this categorization: this is a 66-year-old female with a well-circumscribed, mind you, I'm focusing on the well-circumscribed part here. And then when you look at this, I mean, it's very vascular. There are capillaries here. Interspersed between that are really large polygonal cells and some spindle cells, but overall no mitotic activity, no necrosis. It is really quite cellular, but higher magnification basically gives you the cellular elements that you see. And then this was the cell block, and here you can see some what looks like actually adipose tissue. And then of course, when you have a sample such as this, you can obviously do SMA or HMB45 that can certainly confirm it. Very rare, but it can happen, and it can happen on your docket when you are signing out a case. So be aware of this. So this is another case, very interesting, small lesion, peripherally located, really pink, magenta colored material. But main thing is the nuclei are there, but they are spaced apart. They are not really closely approximated. The nuclei are not showing any binucleation, magenta color. You probably know what this is. And this is the cell block, giving you nice pieces of cartilage. This is the smear, the pap stained smear, giving you cartilaginous material, which you saw on DiffQuick. So when you have all three elements of your aspirate, DiffQuick, pap stained, and then the cell block, you can easily make a diagnosis of pulmonary hematoma. Commonly, it can be missed sometimes, but when it's there, you should be able to make an easy call. This is another interesting case, highly unusual in this location. Any takers for an outright call? So cells are polygonal, some are spindling, but see these nice little tails kind of coming out of them, interdigitating cells over here and here, low power, intermediate power, and then higher magnification gives you some whirling. And here these spindly kind of processes. In the right location, it would be a very easy call for this group, but this is a meningioma. So unusual findings can be encountered. If you are aware of them, you should actually be able to make an easy call. And this would go into category 4 of the PAP Society reporting system. Suspicious for malignancy category is certainly there. And again, just like in the urine, it's both a quantitative and a qualitative question. You know, based on your clinical information, you are probably dealing with a malignancy, but either the features are not outright there, or a quantitation scenario is in play where there's just not enough for you to make a call. So these are cases which I've had, and these are, I think, a representative of suspicious for malignancy categorization. Case number 1, this is a DiffQuick, and this is all what I had. About 10 cells, but giving you pleomorphism and quite a bit of anisonucleosis, size variation. Look at the nuclear membranes, hyperchromasia, if you may want to think of that based on this DiffQuick. And then this is the papinicula stained smear, similar situation, quite a few cells here, but again, this is the only focus. Anisonucleosis, hyperchromasia, even prominent nucleoli noted. And then this is the cell block, case number 3. Same features there. So this is what I would qualify as a suspicious for malignancy call. Each of these ended up representing an adenocarcinoma call later on. But based on just this focus being noted on 3 separate cases, this is what I would want to give you as a benchmark for calling something as suspicious for malignancy. For making an outright call, the PAP Society doesn't give you a cellular count or numbers, but certainly it's up to you and your comfort level as to how you want to address it. So again, once a call is rendered of an outright malignancy on a limited sample, then you are basically responsible for it, and be aware of pitfalls if they are in play. So again, I would not recommending making outright calls on cases as limited as these 3 cases. Positive for malignancy, and this is basically going to be the focus of the rest of the talk here today. Specimens representing a group of neoplasms that unequivocally display malignant cytologic features. So this is basically the goal of most of our procedures, whether obtained via EBIS or CT guidance. And then some cancer statistics for 2023, both for males and females. You can see that lung cancer in men, estimated new cases, I mean, this is quite a number, 117,000 for men, and similarly for women, it's about 120,000 there. And estimated deaths, I think these are the leading cause of death, lung cancers in both men and female for this current calendar year in the United States. So, I mean, these are some of the raw numbers, and you can see the impact this has basically on our practice. I mean, this is going to yield a very high volume of cases for us, and most of them will be coming to cytology rather than to histology. And again, most of these, I mean, this is the SEER data giving a layout of the number of cases and the percentages of these malignancy from 2019 pre-COVID, and then during COVID. Again, we did see some shift in these numbers for cancers of the lung and bronchus, but most of these will end up being adenocarcinomas or squamous cell carcinomas. So again, I mean, on paper, at least, it looks fairly easy for diagnosis, but you need to really be aware that what the numbers actually are. So we have made progress. I mean, that is really good news for lung cancer patients. Prevention has come into play, mainly because of a decrease in smoking, at least in the US. I mean, take a look at the graph over here, starting from the 1930s. Take a look at the red line for lung and bronchus based cancers. In the 1980s and 90s, we really peaked quite high up there. But again, now we are seeing a downwards trend over here, mainly because of decrease in the smoking rate. And that also is not the only reason we are noting this progress. It's basically because of lung cancer screening. CT scanning has become really good at detecting smaller lesions, and then basically are aspirated accordingly. And then with optimization of diagnostic procedures and collection with EBIS, we have been able to successfully give out a diagnosis. So again, this is really tremendous progress, as you can see, over the past couple of decades. The practice has also changed from not just cytology, but also small biopsies being collected. And most of these samples are the first samples that come to a pathologist, such as you or myself. So again, we have to really work hard on obtaining these samples appropriately, and then collecting them, and not just collecting but optimizing them. So that's where it's very important to accurately characterize the tumors, basically for subtyping them, as well as minimal tumor characterization is also needed for current therapeutic choices, which include targetable mutations, which basically PD-L1 status would be noted, and hence there's a need to preserve material for molecular testing. And that is basically a very difficult task, especially for some cases that we encounter. But again, to be noted that this is really now more and more a focus of our practices. So the WHO came out with the thoracic tumor classification in 2021. This is the most current blue book, and most of the lung tumors are characterized in this. And then based on this, this is the most recent lung cytopathology classification that has just been published. So again, this classification, as you all know, is not just focused on the pathologic diagnosis, but clinical practice and cancer registrations and epidemiologic studies all are in play and part and parcel of building up the WHO classification system. And we basically refer to it for most of our resection samples, certainly. So this has been the evolution from the 60s of the WHO system, from resections, which basically used morphology alone for a diagnosis. But now coming on to 2021, the focus is now more on small biopsies and even cytology samples, which have been included in the WHO system, the main blue book. And the emphasis has certainly evolved from morphology in the 1960s to a much broader emphasis on genetic testing. So that is the key over here. And again, we as practitioners should be aware of it. Some, again, salient features of the system, important changes that this update brought. And I want to really focus on a couple of things that there is a recognition of some entities such as the thoracic SMARC A4 deficient undifferentiated tumor. The WHO classification has focused on this. This has been recognized. An update of the neuroendocrine system has been made. Some of the more benign entities have also been included, such as bronchiole adenoma. And then lymphoepithelial carcinoma as an entity has moved to the squamous cell carcinoma category, which I think is probably the only main feature of this classification update that may impact a cytopathologist for their given practice. So this is something to be recognized. WHO classification, what do they say about the adenocarcinoma subtypes? The list is mentioned over here. I don't really necessarily need to go in detail here, but for the non-mucinous adenocarcinomas, know that there are the acinar, lepidic, papillary, micropapillary, and solid patterns. Essentially, this is a histologic subtyping that is in play here and not necessarily expected from myself as a cytopathologist on my samples. Be aware of them, but essentially on cytology, we will not be asked of these subtypes on these non-mucinous subtypes such as acinar, lepidic, or papillary, and so on and so forth patterns. Certainly, if you can recognize a colloid adenocarcinoma, you can certainly call it, and this is really something to be noted. Squamous cell carcinoma, again, like I mentioned, lymphoepithelial carcinoma is now included in this category. And if you so find it as a cytologic sample, then mainly flag it as primarily as a squamous cell carcinoma, mainly because the treatment is the same now. Lung neuroendocrine neoplasms, essentially it's a 4-tiered system. So carcinoid tumor, which basically is either typical or atypical. They want to now call it neuroendocrine tumor grade 1. And for the atypical carcinoid, it's a neuroendocrine tumor grade 2. And then the carcinoid followed by neuroendocrine carcinomas, which are basically small cell and large cell neuroendocrine carcinomas. And then a small percentage of these tumors can be combined tumors as well. So this is basically an overview. You all probably know it, but it's always good to be aware and updated of what the 2021 WHO classification, mainly for histology, is being called out. And we as cytopathologists should be aware of it. Again, a brief snapshot of what this classification system entails. I think I've already gone through most of these changes that thoracic SMARC A4 deficient undifferentiated tumor has now been included part of the nomenclature. I have not necessarily ever diagnosed this in cytology, but certainly need to be aware of it. Similarly, bronchiolar adenoma or ciliated muconodular papillary tumor, these are some of the new terms for histology, which most likely will not be encountered by a cytopathologist, but just be aware of these changes. Good guidelines. I mean, there's a lot of data here. Certainly, you can take the slide from me later on. But what the goal of this guideline from the WHO has for cytology and small biopsies, try to characterize the tumor as much as possible from your given sample, because treatment is based whether you can characterize it as an adenocarcinoma or a squamous cell carcinoma. So again, that's where collection comes into play. That's where a good cell block collection is important, because that's what you really need for not just characterization, but for confirmation of that characterization based on immunohistochemistry. So that is basically some of the summary outlines they have presented for good practice guidelines. An example of an adenocarcinoma over here, you can see that it's a very cellular sample, so quantitation is not an issue. Three-dimensionality, pleomorphism, anisonucleosis, gland formation, cytoplasmic vacuolation on these diff-quick stained images, fairly easy call. These are the pap smeared examples. This is the cell block. and then again another cell block giving you some degeneration, which gives you an impression that these may be keratinized. But certainly if you do IHC, a single stain TTF1 comes back uniformly positive for these cells. It's a nuclear stain. You can certainly make a call of a primary lung adenocarcinoma. So how would you differentiate, say, adenocarcinoma with that significant reactive change that I showed you in that sample, which had been taken out, actually resected? I think one way of looking at these cases is look at just the nuclear details. Those are the most common and most important ones that you should look for. The chromatin is very helpful. Malignant cases will certainly give you irregular, more coarse chromatin versus reactive atypia. Although with reactive changes, a prominent nucleoli is always there in most cells that you see, but it's basically accompanied with the presence of finer and very slightly coarse chromatin, which is starkly different from malignant cases where it would be extremely dense and coarse. So that's very helpful. And then nucleoli can tend to be definitely much larger for malignancies compared to reactive atypia. Lung squamous cell carcinoma, this is again an example where keratinization is in full display, quite a cellular sample. Background has actually keratin noted, and then higher magnification gives you the full spectrum of what a squamous cell carcinoma looks like. Again, fairly easy to diagnose. These are some examples of non-keratinizing cells over here, clearly malignant. I mean, if you are still in doubt, take a look at the cell block, and that would be very useful for doing a P40 stain. It's a nuclear stain. It's much more sensitive than the previously used P63. This is a new isoform. It's been in use for the last decade for sure, but certainly if it comes back uniformly positive, that will help you in confirming your diagnosis of squamous cell carcinoma. Again, differences between the keratinizing and non-keratinizing squamous cell carcinomas are listed here. Again, chromatin is the key over here, pycnotic in the keratinizing malignancies, and more coarse chromatin in the non-keratinizing malignant cells. So that's basically very helpful. And then nucleoli tend to be less prominent in comparison to adenocarcinoma. So if you are seeing really prominent nucleoli, think of an adeno rather than a squamous cell carcinoma. I mean, this is fairly basic cytologic approach that we've used for a very long time, but again, it's good to kind of revisit it. Poorly differentiated adenocarcinomas versus squamous cell carcinomas, these are very challenging, but again, really try to make an effort in characterizing and separating these subtypes, because treatment will be different for both of them. And here, immunohistochemistry will certainly help you. And the two stains I would recommend are TTF1 to determine the tumor to be an adenocarcinoma, and a P40 nuclear stain for a squamous cell carcinoma. So those would be very helpful. This is a list of immunohistochemical stains that you can certainly utilize. It's a long list. I'm sure you're all familiar with them, but the two good ones to know are TTF1 and P40. If there is a concern for the malignancy to be arising from a non-lung location, the list is long, and depending on where the primary site is suspected, you can appropriately use additional stains. Similarly, I have given out a list here. DPC4 or SMAD4 is a good one. I really want to flag out, because that is certainly used for primary pancreatic adenocarcinomas. So again, it's a nuclear stain noted in about 55% of primary pancreatic adenocarcinomas. But again, remember, 45% of primary pancreatic adenocarcinomas would be negative for it. So what if it's the negative one that metastasizes? So again, use it appropriately. If it's positive, which means it's lost, then certainly you have a diagnosis there of a primary call from the pancreas, which may have metastasized to the lung. So again, these are some examples. So we are at the 11:30 mark, and this was recommended as a time for a break. So can we adjourn for 10-15 minutes? Okay, so I'll continue from there. And I mean, since the topic is rather comprehensive, I do have only one case. So I will probably give you more didactic information for the rest of this talk rather than have some challenging cases there. Thank you for your time.